Now, let's flip the page and see if the opposite might occur, where you might think the cervix is abnormal in terms of fluid in it or distension, and it's really not, okay? A false positive diagnosis. Let's look at some examples. This cervix looks like it might be dilated because it looks like there could be fluid in the endocervical canal. But in point of fact, if you look at the clip carefully, that's a little white line here that you're seeing, which is actually the opposing walls of the cervix. That's actually the endocervical canal. And so therefore there's not fluid, but most people have more echogenic mucosa of their cervix. So in this case, for whatever reason, I don't know, that the echogenic endocervical mucosa is lacking. It's unusually lucent. But if you look at this case, sagittally and coronally, there's no line here, there's no dot here. That is actually fluid in the endocervical canal. Lack of seeing that endocervical stripe, and I'd suggest you do this in 2 directions and look completely from side to side. Make sure there's no endocervical dot or stripe here to suggest that it's lucent mucosa. So that's truly dilated, and this is pseudo-dilated because you're seeing that endocervical line here. So that's very, very important. You don't want to miss a case, and you don't want to overcall a case. What about this case? Well, the cervix, this is translabial, measures 27 millimeters. That's shorter than the 30 millimeters. So we shouldn't be happy with this measurement. But is this really a good scan? Again, it's translabial. Could there be a technical problem? Well, look at the big time shadowing here, obscuring the external os. That's due to the rectosigmoid bowel gas. When you have that, you can't have it's a technically suboptimal scan. And you know, we're always wanting to put calipers on and do measurements. Well, be careful before you do that. Make sure your scan is technically appropriate, because that bowel gas is causing a problem here. Her cervix is not short. When we did a transvaginal scan in this case, you work around that bowel gas, and now we have a normal length cervix. Okay, so that's an important false positive. That's a major problem with a translabial scan, the inability to see the external os because of acoustic shadowing from adjacent rectosigmoid bowel. What about this case? Again, we always want to do our measurements. So here you put a little caliper here, and then that's the other end. You put a caliper here, and how do you measure it? Well, some people might just draw a line because that's easy. But is it good? Absolutely not. That line measures 28 millimeters, and I'm sure you realize that is not the course that her cervix is taking. That's a linear measurement, and her cervix is curved. So you've got to take the time to trace out the way that cervix really, the endocervical canal, the course of it, and in this case it's 42 millimeters. That's appropriate. The linear measurement of 18 millimeters, that is inappropriate. They don't equate. Take the time, look at the course of the endocervical canal and measure it. I think that this configuration of the curved cervix is not that much of a problem in the 3rd trimester, when the cervix is actually, I think, more linear in most cases, but sometimes in the 2nd trimester. And after all, women who have incompetent cervix, that's the time you might want to be following these women. And just don't be sloppy. Put your calipers on appropriately. Get a good measurement. So some of the pitfalls that would be false positives, meaning that you think it's abnormal, but it's really not, it's normal, would be times when you could have what looks like endocervical fluid. The bladder can cause that. You can have fluid from Nabothian cyst or vaginal fluid. We talked about lack of cervical mucus. And the big one is shadowing from adjacent rectosigmoid bowel, causing you not to be able to see the external os when you're doing a translabial scan. The curved cervix is one other pitfall from a technical measuring point, okay? So when we're talking about evaluating the gravid cervix, we've already said transabdominal scan, done most common, but not as good as the other 2 ways of looking. Translabial scan is good, but it has the problem, particularly with the external os, giving us some limitations when we have to measure its length, transvaginal is the best. Now, I'm not going to spend too much time about diagnosing placenta previa, but I want to make some important points. One is we're good for making the diagnosis. Two is that we overcall it. We have false positive diagnoses, so our specificity is clearly under 100%. And what are the problems that we have relate to technical factors? Okay, we already addressed how full the bladder is. That's a technical problem. The degree of previa and the gestational age. I'm sure most of you realize that we particularly overcall earlier on in the second trimester, and then the cervix seems to, or the placenta seems to move away later in pregnancy. So if you're going to be diagnosing previa in the second trimester, make sure you get a follow-up, because there are many cases later on when the cervix is no longer a previa. Also, from a technical point of view, we talked about the bladder distension. Realize that the cervix itself is almost like, let's say a roll of paper towels, okay? It has an anterior component, posterior, and two lateral components. That's all the towels against the cylinder of the paper towels, whereas the endocervical canal. And if you were just to do a sagittal scan and you were insisted on looking at the midline, you could miss a placenta that's coming in from the side. This is a transabdominal approach, and we're looking at a transverse view of the cervix. So in this case, the placenta is on the left side of the uterus, and it's clearly coming upon the ipsilateral cervical wall, not crossing over the internal os, but on the cervix per se. And if all you did was a sagittal midline scan, you would miss that. So make sure you scan from multiple planes and go through the entire cervix. So this would be a placenta that we would call a marginal placenta previa. I'm sure many of you have noted, and we've already mentioned, that the placenta moves with time. Here's an example where there's a posterior placenta there, and it ends here. This is a translabial scan, and this is the endocervical canal. So this placenta is completely crossing over the cervix. It's a placenta previa. But now, 6 weeks later, the same case, again, a translabial scan. Now the placenta is ending here, and the internal os is here. Anterior posterior wall of the cervix here. So now this placenta is just coming to the edge of the posterior wall of the cervix. Some people might call that low-lying if this measurement is less than 2 centimeters. That is the term that we use today for a low-lying placenta. So we've gone from a complete previa here to a low-lying placenta in 6 weeks.